Bismillahirrahmanirrahim. My dear fellows and students and colleagues and all those who are appearing in the family physician examinations or postgraduate examinations or any foreign examinations. I am Professor S. Ali Haider. I am visiting professor of medicine at Jinnah Sindh Medical University, Karachi. Actually, we are dealing with the infection and the disease process, or we can say the infectiology. Means that you are studying the infections. Remember the medicine, if you know the medicine in a powerful path, then you have to know the basics of the clinical physiology, clinical anatomy, clinical pharmacology, and the pathology, about the special pathology, and associated with the clinical microbiology, along with the other some knowledge of the zonal or the focal infections or the focal problems. Then you will become a better internist. So it means that the base of the infection which we are discussing is clinical microbiology. If you know something about these things, then you can understand. I have given 6 or 7 tutorials before. I'm facilitator. I'm not teaching anybody, but I am facilitating it. Mean to give you as much guideline or easy to you to follow it. To clear these examinations, actually, one has to be prepared mentally for any type of the question. So we are taking now the gram-positive cocci. There are 3. One is Staphylococcus, second is Staphylococci, and thirdly pneumococci or Staphylococcal pneumoniae, so-called. First of all, I would talk about 15 to 20 minutes about this infection, that is Staphylococcal infection. A scenario is given, for example, look how it is applied in strep or other infections. A 19-year-old woman present to the emergency department for the worsening myalgia, chills, nausea, and generalized weakness. Her symptoms began approximately 5 days ago. These are the symptoms which she has. We can say the prodromal symptomatology. Now, she denies any recent travel history or sick contacts and states that she is currently menstruating and using tampons. Her temperature is 102 and blood pressure was 88 by 55 and pulse is 115 per minute. Physical examination is remarkable for confusion and widespread macular blanching erythroderma. It is widespread in diffuse macular blanching erythroderma that appears like a sunburn. Now, lab studies are significant for a leukocyte count of about 17,000 per cubic millimeter with a neutrophil leukocytosis. Blood and urine cultures are obtained. She is admitted to the medical intensive care unit and is receiving, she was receiving aggressive fluid resuscitation and intravenous vancomycin and clindamycin. Because the diagnosis made here is toxic shock syndrome caused by the Staphylococcal aureus. Now, these are the cases we usually see but neglect, and probably they are referred to the dermatologist. But it is not the case of dermatologist, because the big thing, first of all, the tampons are the source of infection. The portal angle is here, and around it there is the skin. And Staphylococcus aureus is present as common around the skin entering into the vagina and in the cervix and the uterus, and it's causing the entry into the blood and causing these problems. She developed transient bacteremia and then bacteremia, frank bacteremia, and then she goes into septicemia, and septicemia means that the SIRS, the systemic inflammatory response syndrome, which is seen here very clearly, because the blood culture which is positive, or any culture which is positive, and that is known as the sepsis. It means that she is in sepsis, and because the blood pressure is lower down, she is now developing the septic shock. And this occurs because of this syndrome that is called toxic, because of Staphylococcus aureus septicemia syndrome. Look how we read the diagnosis. If the culture is positive for Staphylococcus aureus, which should be, then definitely the diagnosis is very, very clear. So it is not the case of the dermatologist. Look, the macular blanching erythema. This is the peripheral stigma of the disease. Sunburn, peeling of skins, the white hair, here it is black, white, black, white, black, white, just like a sunburn. Now, staphylococcal infection or the staphylococcal infection is an infection caused by the members of the Staphylococcus genus of bacteria. These bacteria commonly inhabit the skin and the nose, where they are innocuous. They are commensals, but may enter the body through cuts or abrasions which may be nearly invisible. At one time it is not visible. Once inside the body, the bacteria may spread to the number of the body streams and organs, including the heart, where the toxin produced by the bacteria may cause cardiac arrest. So septicemia can cause the cardiomyopathy and cardiac arrest. Once the bacterium has been identified as the cause of the illness, treatment is often in the form of the antibiotics and, where possible, the drainage of the infected area. However, many strains of this bacterium have become antibiotic resistant because of the production of the different substances releasing from the. There are many types of the resistant. Many types of the substances releasing from the bacteria against the antibiotic. For those with these kinds of infections, the body's own immune system is the only defense against the disease. Whether first line of defense, or second line of defense, third line of defense, or the fourth line of defense, it may be the first of all, the cellular immunity is important, and then humoral immunity is important. Both immunity may be innate or may be acquired. And if required, it may be active immunity or it may be passive immunity. This is the division we are going, the immune system is concerned. That system is weakened now or compromised. It is a war against this. The disease may progress rapidly. One can contact staphylococci, but pregnant women, children, and people with the chronic diseases or who are immunodeficient are often more susceptible to contracting an infection. The staphylococcal infections, the type is the localized infections. Many infections can occur with the staphylococcus. Example, the stye, a boil, and other small, a folliculitis, and superficial abscesses or sweat or sebaceous glands involved, subcutaneous abscesses, boils around foreign bodies, large deep infections, that is called the carbuncles, and causing bacteremia, folliculitis, ear infection, localized. Now diffuse skin like infection like impetigo, contagiosa, and cellulitis. But cellulitis will occur with the help of the streptococcus. Now deep local infections, acute and chronic osteomyelitis, septic arthritis, deep local. Now, other infections like asthma and rhinitis, it can cause as invaders, secondary invaders in the common cold. Asthma again, it may cause the asthmatic attack or aggravating the asthmatic attack. Acute and the chronic sinusitis, acute infective endocarditis, sepsis, and necrotizing pneumonia. It may cause the lung abscess also. Now, toxinosis are concerned, the toxic shock syndrome, because the release of the exotoxemia or endotoxemia, the toxic shock syndrome will occur, just like in this patient. Staphylococcus gastroenteritis is a very important infection associated with this. Staphylococcus aureus. This is the first infection which is very common amongst the restaurants and the canteens. Remember, this is Staphylococcus. Within incubation period is hardly 2 hours, and the food poisoning occurs. So, this is a very, very important gastroenteritis. But if it is invading type of the gastritis, specifically the Staphylococcus invading the stomach, the lower, the small intestine, and large intestine, that is known as the gastroenterocolitis, and it is the invading type of infection, and it is, of course, the mortality is much higher in these cases. Now, staphylococcal infections include the closed space infections of the fingertip known as paronychia. It can cause the infection of the nail bed. And another one is a suspected involvement in atopic dermatitis, atopic eczema, including the related clinical trials. Atopic dermatitis is not the infection, but separated with the staphylococcal infection. Those people who are appearing in MRCP examination, part 2 specifically speaking, 30% of questions are coming from dermatology. They are interested in dermatology. 20 to 25% of the cases are coming from rheumatology. So कितना हो गया ये 55%, 60% तो यही हो गया. तो आदमी जब मैं अटेम्प्ट कर रहा होता है MRCP को, तो परेशान होता है कि यार ये डर्माटोलॉजी का एग्जामिनेशन है या इंटरनल मेडिसिन का एग्जामिनेशन. इंटरनल मेडिसिन में सारी चीज़ें आएंगी, साइकेट्री भी आ जाएगी, और क्लिनिकल साइकोलॉजी भी आ जाएगी, ये सब चीज़ें आ जाएंगी. तो वो तो कोई भी जगह से कहीं से भी सवाल they will put. Now, there are 2 types of the staphylococci according to the Coccales positive. It is very important enzyme, it secretes. The main Coccales positive Staphylococcus aureus. This is the infecting organism. Very high infectivity. Although not all Staphylococcus aureus are Coccales positive, most of them are positive. These bacteria can survive on any dry surface, increasing chance of the transmission. It is also implicated in the toxic shock syndrome, streptococcal toxic shock syndrome. During 1980s, some tampons allowed the rapid growth of Staphylococcus aureus, as is in this case also, with infection in which released the toxins that were absorbed into the bloodstream, transient bacteremia and then bacteremia and then septicemia. But it can also cause what is known as staphylococcal scalded skin syndrome. Just like in this case, the sunburn type of a problem also occurring. Cutaneous reaction to exotoxin absorbed into the bloodstream. It can also cause a type of septicemia which is called pyemia. More than septicemia is pyemia. And more than pyemia is definitely you go for the septicemia, septic shock, or the sepsis and septic shock. The infection can be life-threatening. Problematically, the methicillin-resistant Staphylococcus aureus, MRSA, has become a major cause of the hospital-acquired antibiotic. This is nosocomial infection. You know nosocomial infection occurring after the admission of at least 48 hours of the admission, if the patient will be showing the signs of infection, it is possibly the nosocomial. MRSA has also been recognized with increasing frequency in community-acquired infections, and the symptoms of the Staphylococcus infection include a collection of the pus such as boil or furuncle. Boil or furuncle is the same, or abscess. Stye is the boil of the eye. The area is rapidly tender or painful and may be tender or swollen. हैरानी हो कि आपकी बात यह है कि उन्होंने MRCP में स्टाई शो की है अपनी जो फिगर के अंदर, ये उन्होंने पेश की थी. और फिर उसके अंदर सवालात है, द मोस्ट प्रोबेबल ऑर्गेनिज्म इन्वॉल्विंग दिस रीजन इस करके दिया हुआ है। अब इसमें जो है ना बहुत सारी ऑर्गेनिज्म लिखे हुए हैं। आपका सही चॉइस जो है वो स्टेप्टोकोका है। ये प्योरली रीजन है स्टेप्टोकोकस का जो बॉयल करता है। इसमें स्टेप्टोकोका का रोल बहुत कम है, लेकिन सेलुलाइटिस अगर आप कहेंगे तो उसमें दोनों आएंगे। प्राइमरी इन्वेटर स्टेप्टोकोका है, सेकेंडरी इन्वेटर स्टेप्टोकोका है। कॉग्लेज नेगेटिव वाले जो हैं वो स्टेप्टोकोकस एपिडर्मिस। कॉग्लेज नेगेटिव स्पीशी is a commensal of the skin, but it can cause severe infection, immunosuppressed patient and those with the central venous catheters. एक तो ये है मुसीबत, ये जो है ना कुछ भी कर सकती है। ये यूरिनरी इन्फेक्शन करती है फीमेल में बहुत ज़्यादा। स्टेप्टोकोकस सेप्रोफिटिकस, यानी इसका मतलब है कि वो एक कोई भी एक्सटर्नल ऑब्जेक्ट्स है जो कि नॉन लिविंग है, उसके ऊपर ये पाया जाता है। अनदर कॉग्लेज नेगेटिव स्पीशी इज अ पार्ट ऑफ द नॉर्मल वैजिनल फ्लोरा सेप्रोफिटिकस, इट इज commensal, is predominantly implicated in uncomplicated lower GI tract infection in young sexually active. ये और ये दोनों कॉज कर सकते हैं रिपीटेड UTI को। Other streptococcus species have been implicated in human infection, notably the Staphylococcus leukidinosus and Staphylococcus chaldiferi and Staphylococcus capri. These are uncommon infections. They are again related with the commensals in the skin, but they can invade in the body and can produce infection. Etiology is concerned, the open wounds, biggest cause of trouble infection. For example, fracture, open fracture, contact with the infected person or surfaces. Again, the entry of infection is the portal of entry. Weakened immune system is another challenge to the problem. Unwashed linens, we are using it in the operation theatre or in your homes. Infection after surgery, unhygienic environment, and invasive devices like catheterization, like anything which is, you go for the what is called the interactive or what you call the interventional procedures, probably they can infect through Staphylococcus. Clinical presentation, I already said that it may boil, it can cause sty, impetigo, cellulitis, scalded skin syndrome, Staphylococcal, and shock syndrome, methicillin-resistant Staphylococcus aureus. These are the clinical presentations. This is the boils, we call folliculitis. Follicle is involved in this case, and clusters form around it. It should be treated, cut it, and drain it, and give the antibiotics. Impetigo contagiosa, very common infection in children, and a large area is involved with this. This is a macular type of infection of the lesions. Some papules are there. Impetigo contagiosa. Children, one of the common problem. If you invade the body, then it will cause septicemia and septic shock in these conditions. So give the hygienic, environment, local application, and good feeding to the child, and give the antibiotics for at least 7 to 10 days. Now, cellulitis is the infection we see not on the dermis, where the skin has got epidermis and dermis. It is below the epidermis, that is in the dermis, subcutaneous tissue. Cellulitis is primary invader is Staphylococcus, secondary invader is Streptococcus. It is a coagulase positive infection, Staphylococcus, invading secondarily by the Streptococcus with the help of the hyaluronidase. The area of this is spreading, the Lewis sign is positive, the erythema, redness, pain, inability to move, and raise temperature of that site. That is called Lewis response, triple response. This is the carbuncles. Here the infection travels along the facial sheaths and making the multiple sinuses draining, especially occur in the neck and in the diabetics. It is carbuncle is there. So surgical intervention should be there, You should cut it along the facial planes and drain all this pus and give the broad spectrum antibiotics. Staphylococcal scalded skin syndrome. Scald occurs. On the mouth you see crusting and scalding. Again, this is a dangerous condition. It will be treated as burns. As you treat the burns, treat the staphylococcal scalded syndrome like this. It is commonly occurring in the children rather than in adults. But the heavy antibiotics, broad spectrum, should be given to save this person from the shock. Staphylococcal toxic shock syndrome. This is the systemic response of the exotoxin and endotoxins releasing from the staphylococcus. It's causing the shock syndrome. Body is maculopapular rashes all over the body. And management is again the empiric antibiotics should be given here, which are actually the beta-lactam should be given, or the macrolide should be given. Choice is yours. Or the quinolones, or the fusidic acid, or the lincomycin groups, or the other broad spectrum antibiotics should be used in combination, or monotherapy or dual therapy. Underlying organism should be addressed. A regime should be set up. Clindamycin is very important, lincomycin, and preferred first toxin suppression. It's powerful agent. And other antibiotics also, they all are failed. You go for the linezolid or the vancomycin. Specifically speaking, I'm talking about the toxic shock syndrome or skin scalded syndrome, or I will talking about the diabetics patient who have developed this infection elsewhere in the body. They are prone to develop the septic shock. So the vancomycin or linezolid should be given. And it is important to narrow your antibiotic once sensitivity testing returns, because sensitivity and culture should be done. If Staphylococcal aureus is susceptible to nafcillin, this is the beta-lactam, then discontinue the vancomycin and treat with it. First of all, you give this blind therapy, vancomycin. If the susceptibility occurs after the blood culture arrived and is susceptible to nafcillin, or what is the combination is ampicillin with the chlorhydric acid, you will change it to the drug and withdraw the vancomycin and complete the course with this nafcillin or combination of this amoxicillin with chlorhydric acid. Now this is the discussion which I have just made. It's important because there are a lot of questions which are related with it. Number one. Number second is in the oral examination or in the viva voce or in the talks or whatever you call it, in the practical examination, practical side, this is the open discussion. There will be open discussion between the examiner and the candidate. He can ask any question regarding the clinical microbiology. I hope that you can understand it. You should understand before going forth with. And many of us afterwards say that actually the score is less than 40 or less than 44, but they don't know exactly what happened actually. They have selected the wrong option in the MCQs, and that is why they are failing. They are repeatedly failing in this examination. Wish you good luck. Assalamu alaikum wa rahmatullahi wa barakatuh.